Hi, my name is Sanjar Eke, and this video is specifically prepared for nephrology office staff as an in-service. First of all, KDIGO was established in 2003 for the first time with a goal of improving care and outcomes of patients with chronic kidney disease. In addition, KDIGO convened a group of experts to develop guideline recommendations related to diabetic management in chronic kidney disease in the recent years. Diabetes mellitus is affecting more than 8% of the global population, which is exceeding 450 million people at this time. This number is projected to grow over 700 million people by 2045. More than 40% of people with diabetes mellitus will eventually develop chronic kidney disease. For people with diabetes mellitus, chronic kidney disease is a potentially devastating condition, markedly increasing cardiovascular risk. The Kidney Disease Improving Global Outcomes Clinical Practice Guideline for Diabetes Management in Chronic Kidney Disease represents the first KDIGO guideline on this subject. The guideline comes at a time when advances in diabetes technology and therapeutics offer new options to manage the large population of patients with diabetes and chronic kidney disease at high risk of poor health outcomes. The new guideline is organized into 5 chapters. Chapter 1 covers comprehensive care in patients with diabetes and chronic kidney disease. Patients with diabetes and chronic kidney disease have multi-system disease that requires treatment from a multidisciplinary team of healthcare professionals. These patients are at high risk of chronic kidney disease progression and cardiovascular disease. Comprehensive management includes a foundation of lifestyle intervention and risk factor management with additional pharmacotherapy in selected patients. 2020 KDIGO Diabetes Management Guidelines recommend treatment with an angiotensin-converting enzyme inhibitor or angiotensin receptor 2 blocker be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications be titrated to the highest approved dose that's tolerated. Guidelines recommend monitoring for changes in blood pressure, serum creatinine, and serum potassium within 2 to 4 weeks of initiation or increase in the dosage of an ACE inhibitor or ARB. We should continue ACE inhibitor or ARB therapy unless serum creatinine rises by more than 30% within 4 weeks following initiation of treatment or an increase in dose. Contraception must be advised in women who are receiving ACE inhibitors or ARB therapy, and we need to discontinue these agents in women who are considering pregnancy or found out to be pregnant. Hyperkalemia associated with the use of an ACE inhibitor or ARB can often be managed by measures to reduce serum potassium levels rather than decreasing the dose or stopping the medication immediately. If elevated potassium noted, we should first review concurrent drugs, moderate potassium intake, consider diuretics and sodium bicarbonate, and even consider GI cation exchangers, so-called new potassium binders. According to new 2020 KDIGO Diabetes Management Guidelines, ACE inhibitor or ARB therapy should be reduced in the setting of symptomatic hypotension or uncontrolled hyperkalemia despite medical treatment or uremic symptoms while treating kidney failure, defined as GFR under 15 ml per minute per 1.73 square meter body surface area. It's very important to note that the combination of an ACE inhibitor with an ARB is potentially harmful. Mineralocorticoid receptor antagonists which are commonly known as spironolactone or eplerenone, are effective for the management of refractory hypertension but may cause severe hyperkalemia or reversible decline in glomerular filtration rate, particularly among patients with low estimated glomerular filtration rate. Chapter 2 addresses monitoring and targets in patients with diabetes and chronic kidney disease. Hemoglobin A1C is the fundamental tool used for glycemic monitoring of patients with diabetes. Current 2020 guidelines recommend an individualized hemoglobin A1C target ranging from 6.5 to 8 in patients with diabetes and chronic kidney disease not treated with dialysis. As it can be seen in the relevant slide, a higher hemoglobin A1C should be targeted in severe CKD patients such as stage 5, microvascular complications, multiple comorbidities, limited life expectancy, limited or impaired hypoglycemia awareness, limited resources for hypoglycemia management. Chapter 3 of the guideline includes advices and recommendations on lifestyle interventions in patients with diabetes and chronic kidney disease. The work group recommends consumption of balanced healthy diet that is high in vegetables, fruits, whole grains, fiber, legumes, plant-based proteins, unsaturated fats and nuts, and lower in processed meats, refined carbohydrates, and sweetened beverages. The work group recommends that daily dietary protein intake should be maintained at approximately 0.8 gram per kilogram body weight. For patients treated with dialysis, in particular peritoneal dialysis, an increase in daily dietary protein intake to 1 to 1.2 gram per kilogram body weight is advised to offset catabolism and negative nitrogen balance. The work group suggested that sodium intake should be limited to under 2 gram per day, consistent with the KDIGO guideline on blood pressure management and international guidelines on the prevention and treatment of cardiovascular disease. Patients with diabetes and chronic kidney disease have lower levels of physical activity along with reduced overall fitness levels as compared with the general population, but very few clinical trials have examined the impact of different exercise programs and implementation of routine physical activity in this population. In the general population and in those with diabetes, improvement in physical activity levels offers cardiometabolic, kidney, and cognitive benefits. Thus, moderate intensity physical activity for a cumulative duration of at least 150 minutes per week is recommended and sedentary behavior should be avoided. It's often necessary to individualize the advice for implementation to be successful. For obese patients, weight loss may help improve glycemic control, blood pressure, other metabolic parameters, and clinical outcomes. However, evidence review did not yield convincing data demonstrating clinical benefits of weight loss interventions among people with diabetes and chronic kidney disease. Chapter 4 covers anti-hyperglycemic therapies in patients with type 2 diabetes and chronic kidney disease. New anti-hyperglycemic drugs have been developed and approved for clinical use, including sodium glucose cotransporter 2 inhibitors, glucagon-like peptide 1 receptor antagonists, dipeptidyl peptidase 4 inhibitors. Many drugs within these new classes have been tested in large clinical trials of people with type 2 diabetes mellitus. These trials provide substantial evidence to inform treatment. Guided by rigorous systematic review, the work group synthesized these data to recommend preferred courses of therapy for patients with type 2 diabetes mellitus and chronic kidney disease. Data evaluating new drugs and comparing treatments are sparse for patients with type 1 diabetes mellitus and chronic kidney disease, for whom therapy focuses on insulin. Therefore, anti-hyperglycemic management in type 1 diabetes was deferred to existing diabetes guidelines. The guideline recommends the glycemic management for patients with type 2 diabetes mellitus and chronic kidney disease should include lifestyle therapy, first-line treatment with metformin and an SGLT2 inhibitor, and additional drug therapy as needed for glycemic control. The work group concluded that most patients with diabetes, chronic kidney disease, and an estimated glomerular filtration rate equal to or above 30 ml per minute would benefit from treatment with both metformin, which is an inexpensive and generally well-tolerated medication that effectively lowering blood glucose, and an SGLT2, which has been demonstrated to offer substantial benefits in reducing risks of chronic kidney disease and cardiovascular disease. When these drugs are not available or not tolerated, or when they are insufficient to attain individualized glycemic goals, additional drugs should be selected based on preferences, comorbidities, eGFR, and cost. In general, GLP-1 receptor antagonists are preferred additional agents because of their demonstrated beneficial effects to reduce cardiovascular events, particularly among people with prevalent atherosclerotic cardiovascular disease, and also their potential to prevent onset of severely increased albuminuria, formerly known as macroalbuminuria, and possibly slow decline in eGFR. Metformin has been shown to be effective in reducing hemoglobin A1C in patients with type 2 diabetes with low risks for hypoglycemia in both the general population and patients with chronic kidney disease. In addition, metformin helps to prevent weight gain, achieve weight reduction in obese patients, and reduce cardiovascular events, as shown in the United Kingdom Prospective Diabetes Study (UKPDS). Metformin is excreted by the kidneys, and accumulation with reduced kidney function may increase risk of lactic acidosis, which is low in absolute terms. Therefore, eGFR should be monitored for patients treated with metformin. Metformin dose should be reduced when the estimated GFR is less than 45 ml per minute, and for some patients with eGFR 45 to 59 who are at high risk of acute kidney injury. Metformin should be discontinued for patients with eGFR less than 30 ml per minute. Metformin may cause vitamin B12 deficiency, and B12 monitoring is advised for patients with long-term use, generally over 4 years. SGLT2 are the new kids on the block now. They are evaluated in patients with type 2 diabetes in 3 cardiovascular outcome trials, which are called EMPA-REG outcome, CANVAS trials, and DECLARE-TIMI trial. There is also one dedicated kidney outcomes study conducted specifically in a CKD population. These trials showed consistently large beneficial effects for reduction of cardiovascular events and CKD progression. At the time of this publication, there is a new study being submitted to 2020 European Society of Cardiology meeting, which demonstrated a substantial risk reduction in the primary endpoint, which is sustained over 50% reduction in eGFR, kidney failure, or renal or cardiovascular death, compared to placebo. Results were similar by diabetes status and baseline levels of eGFR and albuminuria. In addition, the cardiovascular benefits of an SGLT2 inhibitor were confirmed in 2 trials of patients with heart failure and reduced ejection fraction, called DEPA-HF and Emperor-reduced studies. Adverse events included genital mycotic infections, diabetic ketoacidosis, and in one study, a concern for lower limb amputation. Rates of severe hypoglycemia were not increased, except in some subsets of participants treated with insulin or sulfonylurea. Again, we should mention here that SGLT2 inhibitors function by excreting glucose into urine, so generally per mechanism not expected to cause hypoglycemia. Benefits of SGLT2 inhibitors were observed across all categories of eGFR as low as 30 to 44 milliliter per minute, and albuminuria, normal albumin excretion, being included, despite reduced glucose lowering potency at a lower eGFR. Benefits were out of proportion to reduction in hemoglobin A1c and did not appear to depend on glucose lowering. On the basis of this data, the KDIGO Diabetes Management in CKD workgroup felt that most patients with type 2 diabetes, CKD, and an eGFR over 30 ml per minute would choose treatment with SGLT2, regardless of albuminuria or level of glycemic control. For patients in whom additional glucose lowering may increase risk of hypoglycemia, such as patients on insulin or sulfonylureas and currently meeting glycemic targets, it may be necessary to stop or reduce the dose of an anti-hyperglycemic drug other than metformin to facilitate the addition of an SGLT2 inhibitor. In other terms, current guidelines recommend consideration to take one of the antidiabetics out to create space to use SGLT2 inhibitors. All patients should be educated on potential adverse effects, and follow-up should assess glycemia and adverse effects. SGLT2 inhibitors cause modest volume contraction, blood pressure reduction, and weight loss. For patients at risk for hypovolemia due to concomitant diuretic use, providers should consider decreasing dose of a diuretic, advise patients about symptoms of volume depletion and low blood pressure, and follow up volume status after drug initiation. On average, SGLT2 inhibitors cause a modest initial reduction in estimated GFR that is hemodynamic in nature and is reversible. Long-term benefits with regard to GFR preservation are observed despite this initial decline, and a reversible decrease in eGFR with commencement of SGLT inhibitor is generally not an indication to discontinue therapy. In Credence trial, canagliflozin was continued among patients whose eGFR fell below 30 ml per minute during the study. Based on the Credence protocol, it's reasonable to continue SGLT2 inhibitor even if the GFR falls below 30 ml per minute, unless not tolerated or kidney replacement therapy is initiated. Kidney transplant patients may benefit substantially from SGLT2 inhibitors, but may also be at higher risk of infectious complications, and as a result, SGLT2 inhibitors were not recommended for transplant patients until additional studies are completed. I would like to touch briefly on another group of medication which is recommended as a new addition to SGLT2 and metformin, almost as a second step. These medications are called GLP-1 receptor antagonists. They are mostly injectables and they stimulate the incretin hormone pathway. They have been shown to substantially improve blood glucose and hemoglobin A1C control, confer weight loss, and reduce blood pressure. More importantly, several GLP-1 receptor antagonist agents have been shown to reduce major adverse cardiovascular events in patients with type 2 diabetes and high cardiovascular risk. In addition, these same GLP-1 receptor antagonist agents have been shown to have favorable kidney benefits with substantial reduction in albuminuria and possibly preservation of estimated GFR. In patients with type 2 diabetes and chronic kidney disease who have not achieved individual glycemic targets despite use of metformin and SGLT2 inhibitors, the current KDIGO diabetes management guidelines recommend addition of an GLP-1 receptor antagonist. Regarding use of GLP-1 receptor antagonist, lastly, I would like to add that the cardiovascular outcome trials included patients with estimated GFR greater than 15 milliliter per minute, whereas data with those medications in more advanced CKD is limited and use is not recommended. The last but not the least, Chapter 5, Approaches to Management of Patients with Diabetes and Chronic Kidney Disease. Informed decision-making requires that patients are empowered for self-management through education programs. These include face-to-face, group-based, or digital self-management programs. Ideal programs are tailored to individual preferences and learning styles and are continuously re-evaluated. Patients with diabetes and chronic kidney disease have multiple comorbidities, high risks of developing hypoglycemia and adverse drug reactions, multiple lifestyle demands, and psychological factors that influence behaviors and clinical outcomes. These clinical needs call for a concerted approach to care delivery to stratify risk, triage, care, empower patients, and support decision making in a timely manner. Given the large number of patients with diabetes and chronic kidney disease, the comparatively few healthcare providers, and the silent nature of risk factors and complications, it's recommended to leverage the complementary knowledge, skills, and experience of physician and non-physician personnel. A team-based and integrated approach to manage these patients should focus on regular assessment, control of multiple risk factors, and self-management to protect kidney function and reduce risk of complications. In the last section, the guideline creators provided a circular uh, figure which nicely depicts the uh, targeted patient goals for selecting the right medications. This figure is excluding the SGLT2 inhibitors, but it's interesting to note it shows more suitable medications and less suitable medications in two circular layers. One of the medication selection purposes, if weight loss is important, would include GLP-1 receptor antagonist. And the medications less suitable for a patient with a goal of weight loss would include sulfonylureas, insulin, and TZDs. If a patient is suffering heart failure, the most suitable medication group would be GLP-1 receptor antagonist, and the least suitable medication group would be TZDs. If a patient is having GFR under 15 or stage 5 CKD, the medications that would be more suitable would include DPP-4 inhibitors, insulin, and TZD, and less suitable ones would include sulfonylureas with the risk of hypoglycemia. If low cost is what the patient is requesting, sulfonylureas and TZDs would be in the group with a lower cost, and the less suitable options would include GLP-1 receptor antagonist, DPP-4I, and insulin. The circular figure also provides us preferable agents in a patient who has high risk of hypoglycemia, who generally includes patients with advanced kidney disease, which is the group that we are uh, encountering on daily basis. So the medications to avoid hypoglycemia would include GLP-1 receptor antagonists, DPP-4 inhibitors, TZDs, and AGIs. Less suitable medications for a patient at high risk of hypoglycemia would include sulfonylureas and insulin.